Hello and welcome to the AABIP podcast. On this podcast, we go one step beyond publications and guidelines to speak directly with leading experts in interventional pulmonology. This podcast will address not only fundamental topics in exciting publications, but also unconventional topics for which the evidence base isn't that robust. The views expressed on this podcast are those of the speaker and not necessarily endorsed by the AABIP. This is your host, Udit Chadha, an assistant professor at the Icahn School of Medicine at Mount Sinai. And with that, let's dive into the next episode. Hello, everyone. Our topic for discussion today is photodynamic therapy, and our guest today is Dr. George Cheng. Dr. Cheng is an associate professor of medicine and the director of interventional pulmonology at UCSD in San Diego, California. He is a very active and prominent member of the AABIP. When I was deciding on which expert to invite for this podcast, I asked a senior rep at Pinnacle Biologics as to who would be one of the most knowledgeable folks around with regards to PDT, and Dr. Cheng's name was the first name given to me. I'm excitedly looking forward to his views on this topic. Thank you, Dr. Cheng, for joining me on the podcast today.
Thank you, Dr. Chadha, for the kind invite. Before I begin, I do need to declare that I work as a consultant for Pinnacle Biologics, the company that provides Photodynamic. And let's get into it.
Perfect. So this is the first podcast we have that is devoted to a particular technology. Now, PDT is a light activated localized chemotherapy of sorts using non-thermal laser, which is applied 48 to 72 hours after injecting a photosensitizing agent, photofrin, as Dr. Cheng just mentioned. For a technology that has been studied for 4 decades now and has its own journal, this technique is not that popular for restoring airway patency and central airway obstruction. This, of course, is very intriguing. So, Dr. Cheng, what do you think is the main reason that PDT has not gained widespread usage in the US?
Well, that's a loaded question. I think there's several limitations to the wide adoption of PDT in US. One of the first thing to consider is a potential limited training exposure during fellowship. Not all fellowship trainees are exposed to photodynamic therapy in a great amount. And that is largely due to a perceived or rather real danger for prolonged light sensitivity after receiving a photofrin for our patient population. And I think another limitation to potential fellowship training exposure to photodynamic therapy is the consideration of the cost of photodynamic therapy. While it is covered by Medicare, the photofrin, the photosynthesizer, each vial is rather expensive. Photofrin comes in about 75 milligram vials, and we need to provide about 2 milligram per kilogram dose for our patients in terms of infusion. Mm-hmm. So if you calculate that for a 70 kilogram patient, then you're looking at least 2 vials of photofrin. Now, each vial of photofrin runs up around $22,000. So you're looking at somewhere around $44,000 for the treatment, just in terms of the medication alone. Mm-hmm. And another consideration is the need for multiple bronchoscopy sessions. There's one bronchoscopy session that's required after infusion, which we'll get into later about with activation. Mm-hmm. And then you have to wait, and then you have to do another bronchoscopy session to remove any sloughed off dead tissue. And one final consideration is, when you are delivering this treatment, you have to get approval and training processes for these medication, not only in one's institution's pharmacy, but also in terms of the infusion center that you have to work with to deliver this medication, the photofrin, into the patient. And you also have to have an integrated process to provide patient education. Mm-hmm. So to set up a photodynamic therapy capability in one's institution require three different a different part of the hospital to work together, and I think that includes the pharmacy, the infusion center, and the bronchoscopy suite. So that in itself is very challenging whenever you have a treatment process that is requiring multiple different departments' involvement.
Hmm.
And finally, to think about, what are your other options for treatment? So we have other more immediate effect tools,
Hmm.
such as APC laser, electrocautery, or cryo or radiofrequency ablation. Um, and 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 then some will argue, well, that's not a fair comparison because you have immediate effect tools versus PDT is a more delayed effect. Well, then
Hmm.
you also have external beam radiation therapy that are readily deliverable for our patient.
Yeah.
So as such, the photodynamic therapy became more of an afterthought in terms of treatment modalities that's available to our patient,
Hmm.
which I think is quite unfortunate. I think there is a distinct place for photodynamic therapy for our treatment modalities.
Absolutely. So just to summarize what you're saying, so there's training, there's expense, it's cumbersome, and we have alternatives. So PDT has not gained widespread usage, but clearly you and I are still using it in some scenarios. So let's try to dive into some of the evidence for PDT. So PDT in general, if you look at all the studies, improves dyspnea and airway patency in approximately 80% of the patients with malignant CAO, malignant central airway obstruction. So in what scenarios of airway obstruction are you primarily using PDT?
Yeah, so I think this is a great opportunity for us to review what PDT is approved for.
Hmm.
Now, PDT can be used as a primary treatment modality or an adjunctive treatment modality. In the case of the malignant CAO, you have to decide clinically if you have a patient who can actually undergo PDT treatment course. And that they will be compliant to the period after treatment, specifically the period about 30 days after treatment when the patient is photosensitive. Keep in mind that PDT has been FDA approved for treatment of early stage lung cancer,
Hmm.
specifically the microinvasive endobronchial non-small cell lung cancer patients. In home surgery or radiotherapy is not indicated. Um, Also, it is approved for palliation of central airway obstruction due to malignancy, reduction, specifically for reduction of obstruction and palliation of symptoms in patients with completely or partially obstructing the bronchial disease. Now, there is a specific patient selections when you're providing these type of treatment for these bronchial obstructive disease because there are concerns with critical airway obstruction if you were to treat it without debulking, if you were to just use PDT alone.
Hmm.
And finally, in GI field, specifically esophageal CA, that are completely or partially obstructing that cannot
Hmm.
be satisfactorily treated with other modalities such as NDAC laser
Yeah.
or ablation of high grade dysplasia in Barrett's esophagus in patients who do not want to undergo esophagectomy.
Hmm.
Um, so I think, in my opinion, the best way for us to use PDT as a primary modality is really for those early stages
Hmm.
microinvasive endobronchial disease. As I believe that PDT offers a great coverage to treatment and
Yeah.
treatment to reach the areas that may appear normal on white light bronchoscopy,
Yeah.
so that you can actually treat and create that negative margin that we want.
Hmm. Perfect. Yeah. And I think another scenario in which I like it for palliation is in those extensively invading tumors, where, if the extensive whole length of the left main bronchus and extending into the upper and lower lobe. Sometimes I feel in those scenarios, PDT does work well where other modalities would be too cumbersome and difficult to use.
Yeah, I agree with you. And I think in terms of tumors that tend to bleed a lot, I feel like PDT offers a great adjunctive modality because it creates a fair amount of dead tissue and really does not create a lot of bleeding during its treatment if we're careful in terms of placement of our fibers.
Absolutely. And you alluded to this a little bit. So, based on the available evidence and how PDT works, can you explain to us why PDT is probably the most effective modality for CIS?
Yeah, of course. Well, but first we have to think about, let's review how the mechanism, how PDT works.
Absolutely.
As you understand, the photofluorescent, the photosynthesizer is usually injected 48 hours prior to the light activation. As mentioned prior, this concentration is up to 2 milligrams per kilogram for our patient. And this is uptaken preferentially in tumor slash rapidly dividing cells, but overall, all the cells uptake some of these of this first generation photosynthesizer.
Hmm.
Light activation occurs usually with a laser diffuser that we place after 48 hours after the injection of the photofilm, and the laser is usually fired at 630 nanometers.
Hmm.
This activates sulfurin and creates a variety of different mechanisms through which we'll visit. And then what we'll do is we wait for 40 hours after activation to debride any dead tissue.
Hmm.
Now, when I speak to my patients, I usually describe this as imagine I'm giving you the worst sunburn of your life inside your airway.
Hmm.
Because it's very much that way. That's something that our patients can relate to. Almost every one of us had experienced a really bad sunburn before.
Oh, talk about yourself.
So yeah, so it's a way for me to help my patient to relate what type of treatment that this is really providing.
Hmm.
So in terms of mechanism, um, well, there's few different mechanisms. There's a direct mechanism where the direct cellular damage can occur with photofluorescent activation, resulting in apoptosis. But more importantly, photofluorescent activation creates radical oxygen species that leads to cell death. There's also a component where inflammation that occurred after treatment causes thrombosis of the vessels and causes ischemia to the area, and that also causes additional cell death. And finally, there's an inflammatory immune response that's often elicited during this treatment plan. Now,
Hmm.
with this in mind, because the light activation at 630 degrees can penetrate up to about 5 millimeters in radius in terms of treatment, and it actually covers a good area of a treated disease. Um, so that's why I think that it's really ideal modality for an CIS,
Hmm.
because you can actually treat again the areas that may even look normal under white light bronchoscopy, but you still cover that area with your treatment.
Hmm. So just to summarize again, there's this abscopal effect in addition to the fact that PDT covers non-visible tumor. But I've seen that you can't see it on NBI either. And later on, when you see the tumor slough, it's pretty extensive. So probably a lot of non-visible tumor to the naked eye or white light bronchoscopy is being treated with PDT.
Agree.
Um, so if so do you when you rebronch a patient for cleanup, if you don't see an adequate effect at the 48-hour mark, do you usually re-expose the patient to light or do you wait longer?
Well, that is patient dependent, but you can reactivate at the bronchoscopy when initially intended for debridement. And the reactivation, you can reactivate in the same amount or you can reactivate in less amount. Usually
Hmm.
I modulate my amount of reactivation by modulating the time instead of the power that we use.
Okay. Hmm.
Um, and uh, uh, and that is again truly patient specific. And in a lot of times, what I like to do is the way that I approach this is if I have bulky tumors, I tend to debulk first.
Hmm.
And then what I do is I wait about 1 to 2 weeks for a patient to recover from that initial bronchoscopy. This is my practice. There's no evidence in terms of
Hmm.
supporting this is the right way to do it. This is just I've seen the most effect.
And just to
Um,
clarify, you're talking about
yeah,
palliating central airway obstruction and
that's
not
right.
for
That's correct.
CIS right now.
That's correct. That's correct. So for large bulky tumors, I debulk with a variety of different modalities of your choice. Could be mechanical, could be with electric cautery, could be with a radio frequency, and then bring the patient back in about 1 to 2 weeks, and then perform photodynamic therapy at that time, and the, usually with an intent to remove the residual disease after after the debulking. And then at the time when I actually remove the slough off the dead tissue, I hit it with a cryotherapy to the affected area, instead of using another round of photodynamic therapy. And the reason I do that is using multimodality approaches. And when I see the area of treated disease that are dying or died off, and there's certain areas of erythema that's still left remaining, when I hit that with cryotherapy, I feel like I'm providing a different modality of treatment. So far, from my personal experience, I have treated this way about 4 different patients with a variety of different endobronchial obstruction. Some of them are quite large, and I was able to get sustained effect. When I say sustained effect, meaning tumor response that was sustained up to about the longest about 2 years.
Okay. So just to clarify a concept that you alluded to, so if you do re-expose a patient to light, you use a lower dose by shortening the time interval. And I think what George means by that is we'll go a little basic physics recap where joules is watts times seconds, and the usual dose in PDT is 200 joules per centimeter. And this implies that with the standard 400 milliwatt per centimeter power used, the illumination time is 8 minutes and 20 seconds. So when you lower the dose, you can either lower the power or you can lower the time. And Dr. Cheng is saying that he prefers lowering the time. And that's what I've seen most people do as well in personal conversations.
Yeah, and I think it's easier. You're there in the room with your bronchoscopy staff, and I think it's just easier to tell your staff to say, "Hey, we're gonna do 200 seconds here, and 100 seconds here." So it just makes it easier sense, more intuitive sense for them.
Yep, absolutely. So there are a couple of fibers that come with Pinnacle Biologics PDT, and they're flexible and rigid diffusers. The rigid diffuser isn't really a rigid diffuser; it's more like a semi-rigid diffuser used through a flexible scope. But how do you decide on the length and type of diffuser that you're going to use to expose the tumor to light?
Oh, that's great. So there are indeed several different types of diffuser. So you have the rigid, as you mentioned, and the flexible. Now the rigid diffuser, I believe, comes in 1.5, 2.5, and 5 centimeter variety.
Mm-hmm.
The flexible diffuser comes in 1, 2.5, and 5 centimeters. Now it really depends on the location, the treatment location, and what you intend to do when you are where do you want to specifically place the diffuser. So for instance, if you are treating a upper lobe posterior segment or apical segment tumor, and you need to make that curve, you will better suit it for a flexible diffuser. Now, if you were to say there's a central tumor or in the right main stem bronchus, and you need to pierce through the tumor and treat it interstitially, then the rigid fiber will be your go-to because it allows you to actually penetrate through the center of that tumor. And remember, the radius of treatment for photodynamic therapy or the light penetration is about 5 millimeters. So in the diameter is about 10 millimeter treatment effect. I almost always use a 2.5 centimeter fiber. In terms of the central airways, I never go up to 5 centimeters because I think it just covers too much ground.
Yeah, it's probably for GIUs.
Yeah, and I think 1 centimeter sometimes I use for the lobar disease, small tumors that are in the apical or the posterior subsegment. that needs a little curve there. So 1 centimeter and 2.5 flexible,
Mhm.
is sort of my go-to.
Perfect, perfect. So before we dive into the complications that can happen, I must clarify that PDT is generally contraindicated in lesions associated with tracheoesophageal fistulas, obviously those which have just pure extrinsic compression, and those adjacent to a major blood vessel. And the teaching that I've been given for this is that if the intraluminal component of the tumor is within 1 centimeter of a major blood vessel, PDT is usually not a good option. Is this what you practice too?
Yes, I agree.
Okay, perfect. So, what are some of the complications that we can expect with PDT other than photosensitivity?
Yeah, so patients can, during the treatment, patient actually can experience chest pain, and substernal chest pain. And this is usually managed with a variety of symptom management of, say, NSAIDs.
So why does that happen? Every patient I've done PDT on complains of some chest pain, and I struggle to explain it.
That's a great question. I think it's partially probably because of the inflammation that you're eliciting. At least that's the way that I kind of explain to myself.
Hmm.
And I wonder how much of the depth of the penetration of the inflammation that's occurring. We don't. Luckily, we don't see a tremendous of cell death that's shows that could lead to, say, bronchial wall dehiscence or a
Yeah.
complete necrosis of the bronchial wall, although that has been reported before.
Okay.
But majority of our patients, we see this kind of inflamed response and feeling pain. But it would be very interesting to actually, a study to look at is to look at the pain that the patient reports. How is that associated with when we go in to do the debridement bronchoscopy? How much destruction of tissue are we seeing? How much
Hmm.
tissue death are we seeing?
Yeah.
Um, that I never did a correlation, but it's very interesting. It's something that we do see for a good amount of our patients who undergo PDT. Now, another thing that we have to keep in mind is, um, besides the immediate effect after treatment for PDT, specifically in those areas I mentioned earlier, in the sublobar airways, you could actually observe bronchostenosis that can occur
Hmm.
after the treatment. So as the tissue heals, you could have a scar, and that scar may lead to stenosis of the airway. And that's also one thing that we want to keep a close eye on. So in the larger airway, say the left main and the right main,
Hmm.
although I have not seen significant bronchostenosis occurring at that level, I have seen at the level of, say, superior subsegment going off, and that whole segment. Um,
I have
uh,
a colleague who had tracheal stenosis
oh,
after
okay.
using PDT for CIS,
Oh
but
wow.
the patient was re-exposed twice.
I see. I wonder. Whether this is something that we have to look at. To see, say, is reactivation associated with the propensity to develop stenosis in the
Hmm.
larger airways.
Hmm.
I don't know if there's any literature out there that states that.
4 decades of research and we still lack evidence. This is
Yeah.
IP. All right. What about respiratory distress? In what patients should I expect? Anticipate this complication.
Yeah. So, in patients who have poor respiratory reserve, and in patients who you expect larger than normal response, or large response that can lead to occlusion
Hmm.
of the airway. So, for instance, a large bulky tumor at the carina falling into the right main stem, and you were to treat that tumor without debulking per se,
Hmm.
uh, uh, then a fair amount of tissue and cell death can occur, and
Hmm.
then it blocks off both the right main, and portion of the dead tissue can fall into the left main, and then all of a sudden you have a patient with significant shortness of breath and critical airway obstruction.
I see. Yeah.
So which is also why, when I use PDT, I tend to use it in combination with initial debulking of the tumor. with other modalities before I fire with photodynamic therapy.
So this is a consequence of tumor sloughing, airway edema, but it's sometimes difficult to predict, right? I mean, I've seen people plugging their airways when you're just treating CIS sometimes.
That's correct. That is correct. And sometimes I speak to what we talked about earlier. The amount of tissue that's involved often is underestimated on white light bronchoscopy.
Mm-hmm. And have you noticed hemoptysis being a major issue?
No, not luckily not so far. But there are definitely areas that we need to be very cautious about, specifically, say, the left upper lobe takeoff.
Mm-hmm.
And I think having a good understanding of the location of the tumor and how you're going to approach it, those are all important aspects. But then again, if you're looking at other alternative modalities, say radio therapy, there's also hemoptysis that's associated with that.
Perfect. And of course, the big one, photosensitivity, which occurs in 5 to 20% of the patients in reported literature, but this is an avoidable complication with good education. Easily avoided in New York, where I am, more difficult in San Diego, where George is. So anyway, George, this has been fantastic. Your views on this technology have been truly enlightening. Any closing comments for our listeners?
Yeah. So thank you. First of all, thank you for this opportunity to speak about this technology. But I really want to stress, I think multimodality approach to our treatment is key. Not one technology wins over the other. And when we combine those technologies, we actually will be able to offer our patient the full spectrum treatment options and potentially gain a sustained effect. And it is worthwhile to mention that research is active in this area. And there are newer generations, second and third generations of photosynthesizers that are currently being developed, and some of which are already on market outside of the United States, that are approved for specifically use in lung cancer. For instance, laserin that's approved in Japan for early centrally located lung cancer. These photosynthesizers have a much shorter photosensitivity half-life, so to speak. It is uptaken much quicker and goes away much quicker. So it allows us to a little bit more flexibility and minimize that big downside of photosensitivity over 4 weeks time after infusion.
Perfect. Thank you so much, George. This has been fantastic. And the pleasure's been all mine. Thank you for your time.
Thank you for the invitation. I really appreciate it. Okay.
Thanks. Take care.
All right, take care, guys.
With that, we conclude an exciting episode here on the AABIP podcast. I hope you guys enjoyed listening to it as much as I enjoyed hosting it. Do also check out our website, theippodcast.com, and please do provide us with feedback and suggestions on what topic and which expert you want to hear next. Until next time, take care.